Good afternoon, everybody, and welcome to the webinar. ADI are hosting this webinar today to show our support for our NHS partners at this most challenging of times. Our aim is to support you with the short-term urgent challenges which you're facing, and also in the longer term as the new normal emerges. Mike Farrar is independent management consultant and former chief executive of the NHS Federation and the North West and West Yorkshire Strategic Health Authorities. Mike has been working with ADI and has kindly offered to present to you today. We're going to take questions at the end, but please feel free to post your questions in the chat as we go through, and we will be recording the webinar, so you'll be able to access the recording later. Okay, over to you, Mike. Thank you.
Okay, thanks, Judith, and thank you to ADI for inviting me, one, to do some work with them, but also to input to this seminar. I want to just say a little bit about why I think I've got some legitimacy to talk about this. And Judith mentioned in the introduction that I've been a Strategic Health Authority Chief Executive in the last decade when we had them, and in particular in the North West Strategic Health Authority when we were on that journey to reduce the waiting times from 2000, which stood at about 18 months at the extreme, and we managed over a period of 4 or 5 years to get those to 18 weeks. And clearly at that time there was a lot of new money around, and we were able to inject a lot of cash into the system to increase the supply side. But also we learned 1 or 2 things then about how to manage long waiting and to try and help people engage with that and get clinical outcomes that were as good as we felt they could be at the time, given that at the very start of that we had some very long waits indeed. And over the period of time since the pandemic struck, I've been actually working pro bono at King's Hospital in London as the acting Deputy Chief Exec for 4 months, and I'm still here, but now they're paying me a little bit, which is nice. But I was working really on managing the COVID pandemic, and then actually the recovery and supporting the recovery programme for South East London. So my reason to sort of speak about this and the importance of what we're going to talk about today is a kind of reflection on how we managed to achieve that significant reduction in waiting that made so much difference to people's outcomes in the last decade, and how we're going about it in this particular moment in time, when actually I would argue that the challenge is greater, the waiting lists are now longer than they were then, and actually for a whole variety of reasons people are incredibly tired, and so we need to work as smartly as we can. And we also don't have the levels of cash and money that we had in the last decade to increase supply side. And so I think it's quite useful to think about some of the strategies that we adopted. And the development of clinical validation of people on waiting lists was particularly important for us in the early phases of trying to manage the reduction in waiting times. And I think there's some parallels from those days that I'd just like to talk a little bit now in the context of recovering from COVID, and also to explain why this time round actually we can do it even better than we did last time because of our ability to engage people in their own sort of care pathways in a way that perhaps we relied heavily on professional validation previously, but now we can do this into very much a model of shared care. So I wonder if you could put my first slide on, please. This is really, why does this matter? And really, of course, the key thing is when you've got waiting times as long as they are, and for some people now, sadly, it's approaching 2 years, and we're starting to collect data on people waiting longer than 2 years for care. That's an awful long time. And despite the fact that everybody's worked really hard to keep services going through the second surge of the pandemic, effectively, we're still seeing waiting lists increase, although we've managed, I think, for most of the country to flatten the level of increase from the height of summer when we'd actually cancelled virtually everything else to manage the first surge. And so clearly, at the length of time people are waiting, we have a huge issue about the outcomes that patients are going to get. And the opportunity to continually assess risk for those patients is a really important dynamic which allows us to accelerate our red flag care by the fact that we're trying to validate and still be in touch with people about the nature of the problem for which they were originally diagnosed, if we had a diagnosis. And so hugely important in terms of being able to assess risk in terms of patients, that we have this ongoing dialogue and we're looking at validating the particular original diagnosis and intervention that was prescribed. Second point, again, obvious point, is that by doing so, we can actually get optimal use of resources. And so this is the ability to fast track people into care, but also where people can be offered alternatives, and I'll go and say a bit more about this, or their circumstances change, then we can make sure that we're using the resources we do have to maximum effect. And clearly, in things like the diagnostic area, where this country only has 6 CT scanners per 100,000 population compared to an average in Europe of about 19 per 100,000, in Japan and the States approaching 30 to 50, you know that we really have got to maximise the resources that we've got. And if we can help by validating people and their need and reassessing and continually being able to process, obviously that means that the pace of the whole recovery programme for those people who need care is going to be faster as well, because we're actually managing the personal situations of the individuals on our list. And they genuinely are people, not numbers, when we start to think about where they sit in terms of coming forward for care, or indeed still having to wait for care. And of course, what we found in the early parts of the last decade in the Northwest, that very often by a really good process of clinical validation, trying to reassess and assess the patient need, as particularly for those long waiters, in some cases MSK stands out, and sadly I can't give you the data because we didn't count it that way at the time, but we were aware of it because we were monitoring it. We were getting between 15 and 20% reduction in the number of people needing treatment as a consequence of either offering appropriate treatment, or for a variety of reasons taking them off the list because they weren't suitable anymore because of other things that had happened, or we were able to offer alternative remedies and therapies that allowed them to effectively avoid the intervention that they were first prescribed. And so in that sense, what you can really do is have a big impact on people's care by really actively doing clinical validation. And at the same time, you know, what we're pleased with it when we were doing it before, and I think this is true as we're starting to do it now, is that you can improve patients' experience while waiting. So offering better pain management if conditions deteriorate. We can make sure that people understand how to manage their own condition whilst they're waiting, which often gives us improvements that we hadn't originally understood would be present. And then finally, as I say, we can offer alternatives potentially. And even if the interventions potentially change over an 18-month period, we're able to make sure they get the most up-to-date and effective interventions. And just to illustrate that one of the interventions we had in the Northwest for people on the musculoskeletal pathway who were down for hip and knee replacements was to offer gait therapy, that's G-A-I-T. And what we found is by helping people walk better and more comfortably, actually when they came to reassess their hip and knee scores, they were actually managing the pain better. And in many cases, as I say, about 15 to 20% of cases, people didn't actually need the operation for which they'd been originally lined. So you can see there's real benefit in thinking about clinical validation. And if I'm critical at all of the centre, and you know, everybody's worked incredibly hard on this, if I'm critical of the centre, the phase 3 recovery letter that came out really incentivised extra activity, and it underplayed the opportunity of doing really good quality shared clinical validation, which actually could give us a real benefit as well, so that the activity we were going to do effectively was targeted at the right people. So am I the only person who thinks this? Well, if you can go to my next slide, please. What you can see here is this is from the NHS England document, which looks at the clinical validation of surgical waiting lists, and it's supported by the College of Academic Medical Royal Colleges. And so, it's got a lot of support here, is that there are some key principles, and I'm not going to read all of this because you can read for yourself as I'm speaking, but actually the process of clinical revalidation is a well understood one. And as I said, particularly as waiting times start to drift out, you can see the benefits. And of course, there is a real sense now that as individuals are waiting for care, that there are lots of things that we can do in a very positive way to help support them, not least in the case of the narrowing of health inequalities, which allows those people with significant needs to come forward sooner. We know those people tend to have lower voices in our system, and so the process of validation is a way of making sure that everybody gets equality of access, and we can cope with people in the way which is suited to their personal needs. So the principles are out there and validated, if I can use that phrase, nationally, and supported clinically. And I think it's very important to describe this as not something about taking people off waiting lists, but more about providing appropriate care at the right time in the right way for the right people. So if you move on to my next slide, please. And again, this comes from that document. And what's very interesting about this is it sets a very simple process out. Technical validation, have we got the right people? Are they still with us? Sadly, we know that some people we lose over that period of time, which is another reason to really accelerate care in many situations. We have a box that describes the discussion with the individual patient, and then we have the clinical process, which could lead to people remaining on the waiting list or having surgery postponed or actually removed from the waiting list. And of course, it also allows us critically to expedite treatment where people's needs have deteriorated. And of the benefits of reducing waiting times for people overall, I think that the ability that validation gives us to really red flag and target those people with greatest need is the only way the NHS has, if you like, of justifying how we're going to get back on track and make sure people aren't being damaged by these longer waits. And so this is a hugely important process, not just to help us with waiting list management, but also to accelerate patient care. But what I want to finish on as we go into my final slide is that, in essence, a decade or two ago, what we were doing here was we were largely talking about professional validation that was done. And we were also talking about very often one-off revalidation. And of course, doing this in the era that we're now doing it, we have the advantage of basically having a different relationship with patients where they're involved in shared care, and we have technology to be able to communicate with them on an ongoing basis. And when Judith talks with colleagues in a second about their examples from in Yorkshire about where this has been applied and how relevant it is even in today's environment, what you can see, I hope, is that the opportunity to talk about this in the context of shared care, using technology to connect to people remotely, which we know a lot of people are nervous of coming into our services. But this really revolutionises, if you like, the effectiveness of clinical validation. And what we can really see is that by engaging with a patient to be assessing their needs on an ongoing basis, we're really getting them to really commit to the kind of management of that condition whilst they're waiting, and also committing to what would happen post any operation in terms of being part of a rehabilitation process, rather than relying on the professionals to do all of that and really binding them in to their own care. And we certainly know in terms of outcomes that the more patients are engaged in their own care, including assessing their own need level, we're going to get better outcomes as a consequence. And that building of rapport and trust between the clinician and the individual themselves, and sometimes their carers, is really effective in terms of boosting outcomes. And along with this, because we're able to really optimise the understanding of the needs on an ongoing basis, we can effectively really optimise the capacity that we've got. And we know that one of the biggest barriers to recovering as fast as we'd like is effectively the workload pressure on a staff workforce that really isn't sufficient to meet the needs. So this is also a very positive way for the professions to make sure that they're doing their jobs properly, they're targeting their resources to where there's greatest need. And actually a lot of the weight of assessment being taken on by the patient themselves. That really helps, because who knows better than I do? You know, I often say the professional is an expert in the technology or the technique or the specialty that they have, but the one person who's an expert in me is me. So if I'm able to contribute to my assessment of whether I'm in pain or not, I can probably do that far better using some of the proven evidence-based technologies to try and help me understand that and score and rank that, and help really the clinician with their role in terms of assessing need. So there is a huge advantage now in doing validation the way we do it. And I think my pathway really demonstrates that when you start to apply these kind of principles into this well understood process for validation, not only can you do it differently, you can actually do it better. And my final point, before I pass on to Judith and colleagues, is that this isn't just a short-term issue. We do have a short-term issue around COVID recovery. We do know that when we're adding 3,000 in each region, or whatever that number is per region, to the list each month, that this is a really pressing issue because of the damage that waiting does for care in terms of outcomes. However, what this also spells out is the way that our services should work in the longer term, where we've effectively empowered our patients, supported our patients to be part of their care pathway, and really get this partnership between professional and patient working together. So although validation has a specific issue here in respect of management of waiting times for care, it's not just a COVID thing. This is something which we should be building into our system. And just to give you one final point here, is because we will start to have data on what early warning signals are like, using things like machine learning and algorithms, we will be able to predict and detect deterioration before it even happens when we start to see vital signs start to change. And so the opportunity here to revolutionise the pathways of care and to get ahead of ourselves is also here, which for the longer term is what we need when we know we've got to manage the increasing demand with flatlining resources. So this is a really important conversation this lunchtime about how we use this technique to support the sustainability of the NHS as well as managing COVID. So thank you for that. I'm going to pass on to Judith just to illustrate with some recent examples in Yorkshire. Judith.
Thank you very much, Mike. That's great. We just want to give you a couple of practical examples of things which we have been doing. One which is focusing on waiting list management itself, and another one which is focusing on telemonitoring. These examples come from organisations which we were already working with, and when COVID hit, we reached out and said, what can we do to help? And this was the results of that reaching out. The example in Trust 1 for waiting list management, they wanted to contact their waiting list to provide a service update so that people knew what was happening. They wanted to use my pathway to communicate with the patients and understand where the patients were at, if they still required their appointment, if they had any emergency symptoms, and how they would prioritise those people who still needed their support. They also provided resources for self-management and provided a safety notice so that people knew what to do if they were having emergency symptoms. There were two cohorts, the patients which had been referred to the service but hadn't had any interventions, and the patients which had already received the service but had had their care interrupted. In the case of Trust 2, it was a slightly different scenario. They sent out communications to all their patients on the waiting list of that particular service via email, SMS or letter. Once the patients were registered, they were sent an initial message and some resource for self-management while they were waiting for their appointment. Basically, they were sent a questionnaire asking, did they still want their appointment? Yes, thank you, we'll be in touch. No, please briefly explain why you no longer need an appointment. Have the next slide, please. It's worthwhile noting that in Trust 2, of the people who said they no longer needed appointment, all but one of them said that either their symptoms had got better or their symptoms would not be improved by further treatment. And we got quite different results in each trust. So in Trust 1, 40% of the invited patients registered, and 15% of those patients self-discharged. And that represented an overall 6% reduction in the waiting list for that service. For Trust 2, we've just run one trial so far. Well, actually, the second one was started on Friday, so for the second cohort of 100 patients. So 37 people out of 97 replied, and a further 8 replied via letter, and they've had an overall 22% reduction in, 22% of people self-discharging. But these are different cases, and so we have some observations which we thought we'd like to share with you. First of all, Trust 1 went out to all 13,000 patients on their waiting list. It was all digital communication, no hard copy letters, whereas Trust 2 have done one set of patients. They included non-digital patients, and they were all lower back pain patients. So the expectation was that there would be a reasonably high level of self-discharge in Trust 2. But Trust 2 is also planning to do the same activity with hand surgery patients. They're expecting a much lower self-discharge rate amongst this group. And their main aim in this group is to prioritise who needs the appointment most. Trust 2 also had a range of people already registered for My Pathway. Thank you. Cool. The other thing I just wanted to tell you about was we are doing a remote monitoring activity. So this is currently live in the motor neurone disease service in Sheffield. We're also, in January, we'll be going live with a remote monitoring system for cardiology and respiratory in Sheffield as well. Basically, we were already working with the Sheffield Institute of Translational Neuroscience, and when COVID hit, their initial reaction was, first of all, we don't have consultants available to handle these appointments anymore, and also we don't want people with respiratory issues turning up at the hospital. So over a 3-week period, we set up a remote monitoring system, which essentially asks the patient, or sends the patient questionnaires on a fortnightly cycle, and sends them self-help resources. And the clinician then reviews the responses to those questionnaires and can decide whether anybody needs an emergency intervention. We have a very heartwarming story about a patient who was having problems with her breathing apparatus, really struggling with her breathing. She lived in Lincoln, lives in Lincoln, and is obviously quite a long way away from Sheffield. But the clinician was able to see that this patient had this particular problem, intervene, alter the settings on the machine, and greatly improve that lady's quality of life. So as I said, we're also doing this with cardiology and respiratory, and that will include inputting of vital signs as well. Okay, thank you. So that's just a whistle-stop tour of Mike's thoughts and some of the things which we've practically been trying to do to support everyone during this crisis. So I welcome comments from the floor. Okay, so I've invited the panel up, and we've got Mike and my colleagues from ADI, Sue, who is looking after Trust 1, and Simon, who is looking after Trust 2, in case there's any questions on those. So we've got a question from Alistair from York. Is there a national appetite for clinical validation at an earlier stage in clinical pathways? I think that's one for you, Mike.
Yeah, well, I mean, certainly there is a national appetite. As I said, it's perhaps not given the prominence that I'd like it to have, but across London there is an attempt now to make sure that all the 5 ICSs in London have got a standardised way of thinking about validation and trying to centralise the initiative to support it. Now that might mean that there are a number of agencies or technologies being used to do the validation, but certainly it is more recognised as an appropriate way to manage this. Your point about earlier in the pathway, I think, is a really interesting one, because really, if you think about Tim Briggs's work on Get It Right First Time and managing unwarranted clinical variation, actually the validation process by way of having data and assessments ongoing between patients and their professional, if you like, who's in charge of their care, allows us to look at the variability of interventions and to try and understand what drives that. And one of the big questions of Tim Briggs's work is this word unwarranted or warranted, and how much is that driven by the patient's assessment of their own need as opposed to professional judgment. But what we do know is that you can really make a big difference by trying to take out that legitimate unwarranted variation, by trying to get each of the clinicians to apply the standard evidence-based pathway. So I think there is a lot of value in that. And I'll just make one final comment on that, is that Tim Briggs's work largely started in secondary care. And if you think about trying to manage unwarranted clinical variation in secondary care, actually you're building your house from the second story upwards. Really what we should be looking at is clinical variability in primary care with that early diagnosis and those early attempts to manage the condition, particularly for chronic conditions, obviously, because variability there and unwarranted variability has a big impact on resource use later on in the pathway. So I'm really interested as to whether primary care networks, now they have this role to work with individual practices, can start to get into assessing variability of the primary care intervention and almost using validation kind of techniques to try and capture whether or not we are really getting professional variability or it's driven by the patient themselves in terms of their understanding of their own need. And that would be a really interesting development for validation if we went earlier in the pathway and connected into primary care, not just into secondary care.
Thank you very much, Mike. I hope that answers your question, Alistair, but if you've got any follow-up, then please do put it in the comments. I'm not sure if we have any other questions. If you have a question, please feel free to post it. I'll just give you a few minutes to think about that. In the meantime, I'll just ask both Simon and Sue to make a very brief comment on what the trusts that did the waiting list management, what they saw as the main value of the activity that they've done so far. Simon, can we start with you?
Yeah, certainly. So in Trust 2, it was very much a trial to see whether it was a viable means of contacting patients who had been referred quite some time ago. We're talking probably just before lockdown and during those 3 months. And I think the value there was really just getting in touch with them again and finding out what their current status was, and also being able to offer them some self-care information so that while they're continuing to wait, they're able to look after themselves a bit with some validated resources that we're able to push through the My Pathway app. The other thing that they wanted to try out was different means of contacting people. So we don't just rely on one method like email or letters. We can actually do it in sequence so that you can start off with an email, and then if that doesn't work, if people don't respond, you can then follow up with a text message and maybe a letter following that. So it's partly about managing costs, but also about partly about finding the best means of getting hold of people and putting them in touch with the service. So I think there was a lot of lessons learned, and I think those lessons are now being built into the further engagements that are going to take place in Trust 2 over the coming weeks.
Thank you very much, Simon. Sue, just before I move to you, Simon, there's a related question that has popped up, which is, Is there a clear understanding of what proportion of people on the waiting list are digitally enabled and hence more able to fully benefit from digital solutions?
Yeah, so we gathered some stats on that before we started, because many of these patients were known to the service beforehand. It turned out that we had about 90% of the patients we had a mobile number for. So it was quite clear that we were going to be able to contact them at least by SMS. And about half the patients we have an email address for. And so those patients can obviously be contacted initially by email. And also of the patients that have only a mobile number, many of them are then able to go on and provide us with an email address and engage digitally. So the initial cohort only had about 4% of people that we didn't have any digital contact means, and ultimately about half were able to fully take part in a digital mechanism.
Thank you, Simon. Sue, do you want to make a comment about that from Trust 1? Because Trust 1's circumstances were a bit different, weren't they?
Yeah, and I mean, in terms of what Trust 1 did, it is about the understanding the proportion of people on the waiting list. Yeah. So I think to get a clear understanding of the proportion of people on the waiting list who were digitally enabled, probably that was, I mean, that they put all the invites out digitally anyway. So that was either by SMS or email, and they didn't follow up by letter, but they were obviously fortunate that they had contact either a mobile number or an email address for both of them. And I think to get 40% sign up across those digitally enabled patients was pretty good.
Yeah. So what was Trust 1's overall response to the success of the activity, Sue?
We were just absolutely delighted, first of all, that they could get in touch with the patients and reassure them that they'd not been forgotten. They were very obviously keen to do that, and also give them a service update. And then the other thing was, it just really did release quite a lot of the administrative burden on the service, and it certainly enabled them to focus on the patients who actually needed the care, who actually still needed support from the service.
Okay, thank you very much, Sue. We have another question from Julie James, which is, do you need patient consent to contact them? Simon, I think that's probably one for you.
Yeah. So it's kind of a two-part answer. First of all, we contact patients on behalf of the trust, already having contact details of those patients. But what we're really doing initially is contacting them to allow them to then sign up to use the service. So the first thing that they do, if they're not previously registered, is give full consent to use the digital technology. But bear in mind also that in Trust 2, there was a letter sent out, which doesn't require any further consent, because the letter's being sent on behalf of the trust and is returned direct to the trust by the patient. So we don't have any involvement other than simply sending a letter. So for the digital patients, yes, we require consent so that it conforms to GDPR.
Okay, thank you very much, Simon. I hope that answers your question, Julie. Do we have any other questions?
Can I make a point about that?
Yes, please
Julie?
do, Mike.
Just on the on the consent issue, I think we've really struggled over the years, probably since care.data, where we assume consent right from the beginning and use patient information. And I think the relationship that I try to talk about as being part of the future of the way the service is delivered, which is patients with the NHS working together in a shared care approach, I think does assume that between you and the individual institution that your data is still within your gift. Where it becomes much harder to get the value overall is when we start to try and look at patterns of utilisation and try and use those for planning and redesigning services. And I think we've seen from NHS X and NHS Digital and Matt Hancock commitments to try and make it easier to bring data together at scale so that you can potentially understand this. And the reason why I think that's worth saying is that the phase 3 letter on recovery from COVID makes it quite clear that elective recovery programs will be organised and convened at the ICS level, which means that you do have the potential for a larger number of patients. I mean, we've got these great case studies, but these are still small numbers. But when you start to get the whole of South East London, for example, validating using similar tools and techniques at an at-scale population, you actually are starting to have very valuable data. And when you look at countries like Israel and some parts of the accountable care systems in the USA, they're actually using that data incredibly productively to really sort of one target need and to see patterns of deterioration emerging before they actually happen, so you can prevent the deterioration for the patient. And so one of the key things here is to take full advantage of this kind of opportunity. We do need the centre to really get greater clarity over bringing data together at scale, as I say, maybe on an ICS basis, and really using that productively. And I've never believed that patients, if there was the right conversation with them about why we need at-scale data, would worry about that. It's just that we kind of shot ourselves in the foot early on by effectively taking data and not really behaving well with it. And then that undermined confidence. But I'm really hopeful that as we move into the new era, really, post-COVID, that people will really see the advantage of having big data sets together. And, we can use the analysis to really help patients of the future as well as the ones on the list currently.
Thank you, Mike. There is just one other question, which is, please can we share the slides? And of course, yeah, we'll be sharing the slides and the recording. So I don't think there are any other questions at this stage.
Judith, can I ask people who are listening, because I've got no idea, because I can't see how many there might be 2 of you and you might be doing your emails. I know we've got a couple because they've put their thing, but can I ask people for reaction to what they've heard? Is this something that they've already got in their system? Is it something they're thinking about? Is it something now they've heard a bit more about it? Is now something that they would think, well, perhaps, I should ask some questions about it? I'd be really interested in how because we might be preaching to the converted. We might have lots of people here already doing this and doing it brilliantly, or we might have people for whom this is an introduction to the idea, who might be able to go back and start thinking about it. I'd be really interested if any colleagues are prepared or able to either put in the chat or to just to sort of unmute and speak to us. I don't know whether that's possible technically, but certainly you could put something in the chat. It'd be good to know people's reactions.
Okay, thanks, Mike. So if anybody wants to leave a comment, if they'd like to put it in the chat. There will also be a chance to complete a feedback form, which we'll be sending out later on this afternoon. So by all means, you can leave your feedback at that point, if you prefer. Okay. There's no immediate comments coming through, Mike. So I just want, shall we just progress to the next slide?
Yeah, I'm fine. Obviously, there are two people and they're doing their emails, but there you go.
Oh, hold on, too quick. So there's a question from Dr. Liam Knox, who's involved with the Motor Neuron Disease Project, and he says he's already fully converted, and it would be great to see more of this across the health systems. Thank you, Liam. Alistair.
Sorry, I was just going to say, is this something that I know the Academy of Medical Royal Colleges supported the guidelines on surgical intervention on the waiting list and revalidation, but obviously this has got wider implications than just surgery, and it would be interesting to see if, just on the motor neuron disease stuff that Liam was talking about, whether or not the relevant colleges could get more engaged in promoting it actually as a way of working.
That's an interesting challenge for Liam. So I'll talk to him about it. I'll talk to him about it later. We certainly had originally engaged with the Motor Neuron Disease Association. We're using a lot of their resources, etc. And obviously, there's an awful lot about it on the news these days. So yeah, we'll pose that question to Liam afterwards. Also, Alistair Dewar from York has said that we're aware of the NHS long-term plan and the importance of clinical validation. So York are clearly on the ball there. Okay, if there's no other comments at this stage, then it's just to say thank you. Thank you to Mike, obviously, particularly, but thank you everyone else who's attended the webinar. Thank you for your time. I know everyone's really busy at the moment. If you want to email us with any additional questions, the email address is there on the screen. We will be sharing slides and sharing the recording. So thanks again to everyone who's been involved, and we hope to see you again very soon. Thank you. Bye.
Thank you, everybody.